Okay, moving on for our next topic. We are very honored to have Dr. Aman Patel to come to us from MGH, Mass General Hospital, to talk about optimal treatment of cerebral AVMs post-ARUBA trial. Dr. Patel is someone very close to me and who was my mentor for my interventional training at Mount Sinai more than a decade ago. He's not only a extraordinary dual-trained open and endovascular neurosurgeon, world-renowned, and also the national leader in the field, but also he's one of the most humble neurosurgeons I know and down to earth, and he puts patient safety as the utmost importance. So I learned all I know about endovascular from him owing to him for the foundation I have to be where I am right now. So it's truly an honor and special privilege to introduce Dr. Patel. Dr. Patel currently is the Robert G. and Jean Algerman Endowed Professor of Neurosurgery and Professor of Radiology and Neurology at Harvard Medical School. He's the Vice Chair of Clinical Affairs within the Department of Neurosurgery and Director of the Neuroendovascular and Cerebrovascular Neurosurgery Program at Massachusetts General Hospital, with clinical focus on the treatment of cerebral aneurysms, vascular malformation, and stroke. Dr. Patel leads a multidisciplinary group of neurosurgeons, radiologists, and neurologists with a focus on the care of patients with cerebrovascular disease across the spectrum of neurosurgery, radiology, and neurology. He's the former program director of Massachusetts Mass General's neurosurgery residency program. In this capacity, he was involved in leading the recruitment, surgical training, scheduling, and education activity of 21 neurosurgical residents at Mass General. In addition, he's program director of Neuroendovascular Fellowship at Mass General as well. Dr. Patel is on the executive committee of the American Association of Neurological Surgeons, Cerebrovascular CV section, and involved in the organization of national meetings and courses. He's also a member of the Society of Neurological Surgeons, which is composed of surgical department chairs, resident program directors, and other senior educational leaders of the field of neurosurgery, and which is the oldest neurosurgical professional organization in the world. The society holds up its principal mission of designing curriculum and implementation of neurosurgical residencies and fellowship training in North America. Finally, Dr. Patel is involved in multiple clinical studies as investigators in acute ischemic stroke, hemorrhagic stroke, new device development, and new technology and treatment paradigm for different vascular disease. Let's welcome Dr. Aman Patel.
Tony's much too kind. I didn't need such a long introduction, but I think you guys will look forward to the biplane in the OR. All of our biplanes are in the neurosurgical OR, and compared to everywhere else where I've been, where you always felt like you're in the basement, and it's kind of nice being a surgeon, being where all the other ORs are, and so it leads to a lot more collaboration. So on our floor at Mass General, we have the 2 MRI rooms, a CT room, 4 regular neurosurgery rooms, 2 biplanes, and then vascular surgery works in the 2 Zigos. So, and that's 1 floor. So everyone's very close, so we can even use the Zigo. It's really changed how we've done, or how I approach anterior circulation lesions, because we go there, we do an angiogram. It can't be treated endovascularly. We just turn the table, clip, do the post-op angio, get out. And so we do all our AVMs there as well. So I think you'll look forward to that. It really works well. So after all the other talks, which have so much more incidence, this is going to be a more esoteric talk. So because AVMs are not as common, but they're an interesting disease, and so what I want to do is review cerebral AVMs. Some of it will be a very basic review on the disease, go through the variety of treatment options in light of the ARUBA trial, which I'll explain in a little bit, and then kind of try to come to some conclusion as to how we should approach AVMs. The higher, okay. Oh, for the online crowd, the I will get us back on time because I won't bore you with an hour-long talk on AVMs. So these are my disclosures, not really relevant to this talk. So a little historical perspective on AVMs. These were first described in the 18th century by William Hunter, who described it as an abnormal connection between artery and vein. First intracranial AVMs were described in 1854 by Luschka, and we're familiar with the foramen of Luschka, and Virchow in 1857. First treatment of an AVM was in 1889, and then Cushing and Dandy in 1909 published an individual series in 1928. There aren't that many surgeons in the room, likely, but for anybody who's operated on an AVM, it's frankly amazing these guys were able to operate on AVMs in 1928 without a microscope, without transfusions. I mean, even now they can become bloody messes very fast, and it's pretty amazing. So a little bit on the incidence in natural history. They're the most common intracranial vascular malformation. They're 1/7 to 1/10 as common as aneurysms. 90% of them are supratentorial. 64% of cases present by age 40, and 30 to 50% of them present secondary to hemorrhage, and the risk of death from a hemorrhage is 29%. So how do they present? We see many asymptomatic AVMs, 88% asymptomatic in autopsy series. In clinical studies of looking at radiology reports, vascular malformations are found in 2 to 4% of imaging studies that are performed for other reasons. And in a population-based study, 40% of the AVMs that are treated were asymptomatic. Focal deficits, we often talk about focal deficits, but really they're pretty uncommon with AVMs. Less than 10% of AVMs present with focal deficits. Seizures are common. And we talk a lot about steal phenomenon and hypoperfusion, especially if you have a very large AVM that's sucking away blood flow. But again, that's very uncommon. But for focal deficits, a larger AVM, a higher flow AVM, those are much more likely to have focal deficits. But again, it's unlikely. But really, the presentation that we all worry about when we see AVMs is what is the risk of hemorrhage? The best natural history studies that we have are really out of Finland, because I guess the Finnish don't move. They stay in one place for a long time. And so they have follow-up over a very long extended period of time. And I think what's important to remember on these studies is that patients with AVMs who are followed for a long time, a significant portion of them will bleed in their lifetime. The rate that they came up with is approximately 4% per year. You may see a patient that's asymptomatic, but we have to remember that these patients have a lifetime risk of bleeding. So they're not going to develop a symptom in a year or two. And even in their studies, they found that the interval between diagnosis and a hemorrhage was approximately a decade, or slightly less than a decade. So the risk of living with an AVM is a long-term risk. It's not a short-term immediate risk. So how do you calculate the lifetime risk? There is a very complex mathematical formula, which I don't try to do in front of patients, but they've estimated that the lifetime risk is 1 minus the annual risk of not bleeding to the power of expected years of life. So a 35-year-old with a 43-year life expectancy, and if you assume a 3% annual risk of rupture, the lifetime risk is 1 minus 0.97 to the 43rd, which comes to 73%. But the easiest way to calculate this is 105 minus the patient's age, which will give you a pretty good estimation as to what the lifetime risk of bleeding is. So what are the risk factors for hemorrhage? Angiographic factors. The papers, if you look through like a literature search, are all over the place. There are some papers that say there are no significant factors on multivariate analysis, and there are others that say deep AVMs have a higher risk of bleeding. Basal ganglia AVMs have a 9.8% annual risk of bleeding. Posterior fossa AVMs definitely have a higher risk. And then periventricular AVMs, and then patient AVMs that are associated with feeding artery aneurysms have a higher risk because the aneurysms behave like intracranial aneurysms, but are at a higher risk because there's more flow. Again, size of an AVM is controversial. You could see papers that say small AVMs are higher risk. There's others that say big AVMs are higher risk. Spetzer had said that small AVMs had a higher pressure, so had a higher risk. But I don't think most of the studies that you go and you look at it in detail, you'll find that there's really not much of a difference based on size. Venous drainage, I think, is important. AVMs that have a stenosis or occlusion. So AVMs are set up in a way where you have feeding arteries going in, you have a nidus, and then the blood has to come out. And so if you have a stenosis or an occlusion of the outflow, you can imagine that there's going to be a higher pressure in the nidus of the AVM, which will then increase the risk of bleeding. And so when we do angiograms on AVMs, we're really looking for a stenosis or seeing what the outflow is like. And if there's a restriction to the outflow, those AVMs do have a higher risk of bleeding. And that's why deep venous drainage carries a higher risk, because with deep venous drainage, what you get is especially if it's isolated, you have one smaller vein doing the drainage, which then leads to a higher risk. Single draining vein as well. Venous aneurysms, I do not believe carry any higher risk than the feeding artery, than if they didn't exist. So what are the pros for conservative management of AVMs, which means observation? I think the pros are that overall, taking all AVMs into consideration, that at least in the short term, there's a relatively low risk of hemorrhage, and AVM treatment risks are not insignificant. And so that is the reason for some folks advocating that these should just be monitored. And the highest risk factor for hemorrhage is a history of prior bleeding. But I think as I said, not all AVMs are created equally, and some of them do carry high risks. If you have an AVM that's previously bled with a deep venous drainage in a deep location, it's a 34% annual risk of bleeding. Even if it presents unruptured, it's 8% annually. So patient age will play a role. The cons of conservative management is that young patients do have a high estimated lifetime risk of hemorrhage. Unfortunately, many of the studies we have short follow-up time and don't account for the long-term disability of untreated AVMs. AVMs may also enlarge and change over time. And even if the actual mass doesn't change, the flow pattern changes. People develop hypertension as they get older, and these vessels are dysplastic, so they enlarge and the flow within them increase as well. As I mentioned, not all AVMs are the same. There are some that are definitely higher risk. And then finally, the consequences of having a hemorrhage is not insignificant. 33% of patients have moderate or severe disability. 30 days after having a hemorrhage. So with a hemorrhage, again, the morbidity and mortality is approximately 6 to 30%, depending on the study. Most of them fall somewhere between 20 and 30%. And this is variable based on location and size of the AVM. Posterior fossa AVMs have a very significant risk of mortality if with rupture, just because it's a cerebellar hemorrhage. So because of the sort of quote unquote controversy on what to do with AVMs, there was a study, a randomized study called ARUBA, which is a randomized multi-center trial of unruptured brain AVMs. And this was a study that looked at unruptured AVMs that were asymptomatic in adults, and they were randomized to either interventional treatment, which could be endovascular, radiosurgery, or surgery, or a combination thereof, and conservative management for headache and seizures. And the primary outcome of the trial was a composite event of stroke or death. And then there are a whole host of secondary endpoints. The study was halted after 223 of 400 patients. At that time, there were 109 randomly assigned to conservative and 114 to the interventional approach. Patients were well matched at baseline. Most had Spetzer-Martin grades 1, 2, or 3 AVMs. There were a few grade 4s, but no grade 5s. At the time of stopping, the average follow-up was 3 years. And at that time, the primary outcome had occurred in 11 patients in the conservative group and 33 patients in the intervention group. So, you know, there's been a lot of criticisms on this study, which I can talk about on the next slide. But I think if you just look at the last point there, I think that there are a couple things that the way I would view that. One is watching an AVM is not without significant risk. In 3 years, 11% of the patients in the conservative group bled. So that's a significant number. And then it was halted because having an intervention was worse for the patients. But what that means to me is that our treatment complications are too high. So if you could find a way, or if you can appropriately choose a patient for treatment and bring that complication rate lower than 10%, then it would be completely flipped. And because the primary outcome was achieved in the intervention group mostly because of complications or inadequacy of treatment. So what are the limitations? So it's too short of a follow-up. It's a lifetime disease. So people have an AVM for their entire life. And if you have 10% of people bleeding within 3 years, how many will bleed within 20 years or 15 years? Selection bias may limit the generalization of the results. There's so many covariables. AVMs are very complex, which would make it difficult to power with only 223. But I think the biggest issue is that they lumped a variety of different treatments and just said you were treated, right? Somebody can choose to do endovascular. Somebody can do surgery. You could do radiosurgery. And those were put into the treatment arm, which makes no sense because all those treatments are different. Endovascular is unlikely to achieve a cure with most AVMs. Radiosurgery can take 2 to 4 years to work. So if you had radiosurgery and you bled like 2 years later, you still haven't even reached the effectiveness of the treatment, but then it would be classified as a failure of treatment, which doesn't make any sense. And what's remarkable is less than 10 patients were treated with surgery, which is the only treatment that is proven to immediately eliminate the future risk of hemorrhage, of course, at the risk of the surgery. And sorry about the last point for the Swiss in the group, but I think that there definitely was a higher endovascular bias in Europe for aggressive endovascular treatment, which tends not to occur in the US. But I think, just like most things that we treat, the optimal treatment does come down to patient selection. You can't just look at a study and, what's unfortunate about ARUBA is that after it was published, the number of AVMs that were treated in this country just like went down. And everybody just says, okay, well, this trial says you should watch all AVMs. And without any deeper thought in like, okay, well, what if you have this 1 centimeter right frontal AVM in a 20-year-old? I mean, the risks are low. Should you just take it out? So it does come down to patient selection. So what is the optimal treatment of AVMs? And of course, we'll never be able to achieve this. No treatment-induced deficit. AVM obliteration that is complete, permanent, and immediate with minimal convalescence, discomfort, cost, or follow-up evaluation. Impossible to achieve, but you may be able to achieve this in the appropriately selected patient and the appropriately selected treatment. So patient selection. Again, natural history. We know if you look at the charts from Finland, you'll see that over 30 years, 30% of the AVMs will bleed, even if they present unruptured. A greater percentage of them will bleed if they're of a larger size in their study. If we look at long-term excess mortality, which is the number of, these are AVMs that present unruptured at admission, and over a 30-year period, 32% of them bleed. In the first 2 to 3 years, 6% will bleed, but over a long period of time, a significant number of patients will have a hemorrhage. And again, as I mentioned, the risks are very different depending on the AVM. So looking at the anatomy is important. I have this quote from Walter Dandy from 1928, where he's describing AVMs. And so there are large AVMs and small ones, those which are mostly arterial, others mainly venous. Some are superficial, others deep. Some are in highly important areas of the brain, others in portions largely silent. All these factors, and finally the patient's wishes in the matter, must be weighed. It's almost 100 years from there, and I'm not sure I don't think we should approach AVMs any differently than he did 100 years ago. Again, for review, for those that don't know, Spetzer-Martin grading scale is a grading scale of AVMs based on size, location, and deep venous drainage, and the score can be anywhere from 1 to 5. The one thing I should say about the Spetzer-Martin grading scale is that there's a misconception that the grade of the AVM has any implication on the natural history of the AVM. It has nothing to do with the natural history of AVMs. This grading scale is only beneficial in trying to assess what is the surgical risk of an AVM to remove it. That's what it's made for. A Spetzer-Martin grade 1 AVM can be removed surgically with very low risk, and a grade 5 is almost impossible to remove without major morbidity or mortality. And so I think that many people say, oh, it's a Spetzer-Martin this, we should do that, but it's really just done to assess what the surgical risk of that AVM would be. And I think it comes down to degree of eloquence, like brain topography is important. You can't take out an AVM in the language cortex without causing language deficit. This is why like the large core trials on stroke don't make any sense. It's about what is infarcted and what is not infarcted. If you've wiped out your language and your motor cortex, who cares if you're going to save the left frontal tip in terms of outcome? but if you've infarcted your left frontal tip and your motor strip and your language cortex is not affected, then it doesn't matter how big the stroke is in an area that isn't important. And I think this is important to AVMs. So if we look at the risk of adverse outcome by Spetzer-Martin grade when you operate on AVMs, if you have a grade 1 or 2 AVM, the adverse outcome was only in 2% of patients. If you have 3 or 4, grade 3 or 4 in non-eloquent, the adverse outcome goes up because the size of the AVM goes up. And then once you get to grade 3 to 5 or eloquent AVMs, adverse outcome is 21% of patients. So eloquence is important. Grade of the AVM in deciding whether you could remove them surgically is important. So now let's look at ARUBA. In ARUBA, 46% of the patients that were enrolled were in eloquent cortex. And if you're randomized and treated in the eloquent cortex, it's not a surprise that these patients had deficits because we know that any of the treatments carry risk. Also, 40% of the AVMs in ARUBA were deep. And those are higher risk AVMs. So if we look at the surgical results of grade 1 and 2 AVMs versus grade 3 to 5 AVMs, you'll see that there's a pretty good dividing line between grade 2 and grade 3 in the likelihood of deficit after surgical excision. Once you get to grade 3, having deficits, major or minor, increases significantly. This is from Australia. Again, they found the same results as the original studies. Again, the dividing line is between grade 2 and grade 3. And there's a whole host of surgical series, whether it was at Columbia, the Barrow, Dartmouth, Australia, that shows that the surgical results of Spetzer-Martin grades 1 and 2 AVMs is excellent in terms of having a low morbidity and a low mortality rate. In ARUBA, only 55% of patients were Spetzer-Martin grades 1 and 2. So it shows that you can't take a study and just generalize it to all AVMs. And they never did a breakdown of looking at those patients. And only 5% of these Spetzer-Martin grade 1 and 2 AVMs underwent surgery. They either underwent embolization or radiosurgery, whereas they should have been operated on and would have had a lower risk. So what about radiosurgery? Radiosurgery is a great treatment option that opens up treatments for certain patients that can't get treatments, but it's very dependent on volume of the AVM. If you have a lower volume AVM, it's very effective over a time period. So people talk about the fact that, okay, well, there's no risk, but because there's no immediate benefit, there's no immediate risk. Most of the risks come later because of the effects of radiation and because of the sort of the time latency in achieving like protection against bleeding. Because until the AVM involutes, the natural history hasn't changed, and it can take 2 to 3 years. But we do see that as the volume increases, the efficacy of radiosurgery drops. And so if we compare surgery to AVMs for grade 1 and 2 AVMs, if you operate on a patient without complication, their risk of bleeding has been eliminated. So years from treatment, they won't bleed. You will achieve that in patients with radiosurgery, but in those 2 years when you're waiting, some AVMs will bleed during that time point. So if it can be removed without high risk, you're better off removing the AVM rather than giving somebody radiosurgery. surgery compared to radiosurgery for grade 1 and 2, there are fewer postoperative hemorrhages, fewer deaths, fewer new deficits, and a higher angio cure rate, even at 2 or 3 years. And most of the radiosurgery deficits are related to the AVMs that will bleed because of their natural history in the time period that you're waiting for the radiosurgery to work. And, you know, radiosurgery is not without complication. This is a 46-year-old man with seizures, large AVM. I wouldn't operate on that AVM, so I probably would do radiosurgery. And this is, you know, this is him after 6 months, after 9 months. You see all the white matter change surrounding this AVM. AVM's decreasing. He came in with weakness, some language deficits, put him on steroids. Many of them got better. And eventually you get to a point, AVM's gone, essentially, but you're left with all the tissue damage here. AVM's cured, and he still had some residual mild language deficit. Almost certainly less than he would have if we operated on him. But this is a sign that the radiation does have an effect on the normal brain. So what about embolization? So Onyx is what I use most of the time. Used to use NBCA, but I think they both still play a role. And so what is the therapeutic objective of embolization? There's some people that'll say, okay, well, you could achieve definitive cure of an AVM. So the goal of an AVM treatment is to eliminate the nidus of the AVM. Whether you remove it with surgery, radiation causing it to involute, and if you do embolization, you need to fill the nidus of the AVM, otherwise they'll just recanalize. And you can get definitive cure in small AVMs. So here's a occipital AVM with a very defined feeder. If you can get right to the AVM with the microcatheter and then inject Onyx and fill the whole AVM, get a great result. You don't have to operate on it. Here's a larger AVM, but again, very focal, very defined feeder that you can catheterize, form a cast, and get it cured. But the reality is that whether we look at the results of NBCA or Onyx, with NBCA, it was unlikely to achieve a cure in more than 90% of the cases. So about 5% of cases you could achieve a cure. With Onyx, we're kind of settled somewhere around 20% of them that you might be able to achieve an embo cure with the acknowledgement that they have a slightly higher risk of recurrence. And so this is a review of Onyx, and they said 0 to 50% angiographic cure rate, but I'm not really sure why anybody includes a study with 2 patients in the group and then says, okay, they achieved a 50% cure rate. But I would say that the bigger studies fall somewhere around 15 to 20%. So really the reason for embolization is either to eliminate high risk portions of an AVM or for preoperative embolization, and in rare cases, shrink an AVM down so that the volume of radiosurgery decreases, especially for large AVMs. So here's embolization of risk factors. Here's an AVM, SCA aneurysms, feeding to the AVM, pica aneurysms. These things have very high risk of rupture. And so embolizing them eliminates the risk, eliminates the risk of rupture from these high risk components. And I think you do help a patient when you treat these. Preparation for stereotactic radiosurgery, as I mentioned. And so the goal, if you're going to do an embolization for radiosurgery, is if you have an AVM and you just go and pick holes in it, it doesn't help because you still have to radiate the whole volume. You really have to do circumferential or eliminate a portion of the AVM, so your volume of radiation drops. Otherwise, there's no point. You're just taking a risk of embolization without changing the dosage of radiation or the volume of radiation you need to give. And so you really want to target it. And in many cases, it's not so easy to do. But if you have an AVM that's large and has MCA components and ACA components, you may be able to remove the lateral portion and then radiate the rest and decrease the volume and then get a great result after radiosurgery because the target became this rather than the large portion. But really, the main reason we use embolization now is preparation for surgical excision. In fact, all the agents that we have available, the FDA approval is based on proving that the risk of surgery was less after embolization. They're not really approved for standalone use, and we do that, but the FDA approval was based on a reduction in the blood loss and transfusion requirements, reduction in operative time, which for the surgeons in the room, we know it's like an impossible thing, right? There are slow surgeons or fast surgeons. You can't really look at operative time. And really, I think the biggest benefit is occluding the deep feeders of an AVM, because when you're operating on an AVM, it's like a cone going down the brain. And if you could shut down the blood flow coming from the deeper surface is very helpful to the surgeon, because the stuff that's supplying the AVM right on the surface, it's the first things you see, and you can take them surgically. So here's an example of a left temporal AVM, superficial, small. We embolized it. This is what it looked like on angio. Got a good cast. AVM is still filling. And when you go take it out, you see the onyx filling the AVM. And instead of having a lot of blood flow through these, where every time you touch it, it bleeds, you could almost take it out like a meningioma and just work around it circumferentially. So in summary, you have to bear with me on this chart. So I tried to think of, for grade 1 and grade 2 AVMs, trying to look at the different modalities that we have. So if you assume a bleed rate of approximately 50% over 25 years, what I'm trying to see is like, what is the overall risk of mortality or morbidity over 25 years? Because many of the patients get diagnosed at a young age. So if you do conservative management of an AVM, you have 0% cure, 0% procedural cure, 0% procedural mortality, but over 25 years, 50% risk of hemorrhage. So there's a 50% risk of mortality and morbidity for a grade 1 and grade 2 AVM. With radiosurgery, you have a 90% cure rate, procedural risk of 3%, mortality of 2% because of the AVMs that will bleed, and then the hemorrhage risk, this 5% is for the 10% that never get cured, and then the 4% for the patients that wait over a year to a couple years to get their AVM. Risk of mortality and morbidity is 14%, so pretty good. Embolization, 20% cure rate, 5% procedural risk, 1% procedural mortality, but the 80% that you don't cure will have a 40% risk of bleeding. So trying to do embolization alone is no different than just watching an AVM. With surgery in these patients, 99% of them will achieve a cure. There'll be a 5% risk, less than 1% mortality in a grade 1 or grade 2 AVM, less than a 1% risk of bleeding over 25 years because you've cured most of them immediately. So the risk of having morbidity and mortality, which is all front loaded because most of it's because of surgery, is 6%. So chances of surviving intact, hemorrhage-free 25 years after presentation is 45 to 75% with conservative management, 54% with embolization, 86% with radiosurgery, and 94% with microsurgery. So the therapeutic method which successfully achieves the goals of grade 1 and grade 2 AVMs is microsurgical excision in these patients with or without embolization. But if we look at grade 3 and 4 AVMs, I don't even include 5s because we don't operate on grade 5 AVMs. Again, 50% of these will bleed over 25 years. Embolization plus radiosurgery, 43%. Embolization and surgery, significant risk of procedural risk, high risk of leaving behind AVM, mortality, and front loading a 35% risk or a 43% risk when your lifetime risk is 50%, it's kind of hard to justify. So the data is way less convincing for grade 3 to 4 AVMs. So in conclusion, I think what ARUBA proved is that overall AVM natural history can be benign in the short term, but AVMs do bleed. And the risk of bleeding is not insignificant. And that risk needs to be weighed against the treatment risks. All AVMs are not created equally. Ruptured AVMs require treatment. Possibly dividing line for unruptured AVMs may be between grade 1 and grade 2, maybe non-eloquent grade 3s. If somebody's a grade 3 just because of size, you could consider bumping them into that category. The optimal treatment of non-eloquent small AVMs remains surgical excision. Radiosurgery plays a role in the treatment of eloquent small AVMs, and embolization is largely an adjunct treatment and only results in cure in less than 20% of AVMs. And management of unruptured grade 3 to 5 AVMs, you need to proceed with caution. Thank you.
Any questions for Dr. Patel? Eric, as always.
Gary Friedman from Brookdale Hospital. I was impressed by the slide that it's like, I think you said 6% in the immediate period, 12% at a year, and then suddenly it jumps up to 30% by 30 years, if I recall. Is there any pathologic change that occurs in the AVM vessels that makes for this big jump? Like what happens as the AVM ages, and then, is there some change in the vessel that has such a large increase in hemorrhage?
Yeah, I mean, I think several things happen. One is the general hemodynamics of the patient change over that long-term period of time. So things like hypertension and things start to sneak into the general patient. But it's just long-term of very high flow going through these vessels that eventually they do enlarge and get bigger. And I think that they just hit this threshold that in some AVMs they can't tolerate.
It's like an aneurysm in a way.
Yeah.
Okay, thank you.
I have two questions, Aman. As you mentioned, the patient selection stratification, as well as the treatment modality effectiveness and safety are important. So the ARUBA trial in that regard reminds me the LVO thrombectomy trials that before 2015 and then afterwards. So that's a huge difference because of those two reasons. Are there any current concerted efforts from the Society for Neurosurgery or Neurointerventional Society to conduct a trial that, in a way, that's appropriately designed to counter ARUBA's kind of impression for the general audience?
Yeah, I mean, being a neurosurgeon, I know that neurosurgeons just spend a lot of time just bitching and moaning about the trials rather than doing another one. But, I think I think that with the thrombectomy trials, the reason they failed is that the devices weren't good.
But also the patient they treated was just not right patient.
But I mean, I think that you were doing it with like concentric and the first generation penumbra devices, and those things weren't great in achieving recanalization. And we finally got to the stage with stent retrievers, which is where most of the 2015 studies were done with those devices. And we had a device that could finally achieve recanalization. So the first studies failed because people went in for a procedure, but you never achieved the goal of the procedure. I think Aruba failed because I did the radiology review for some of the DMSB. There were no right frontal AVMs that were enrolled in Aruba. They were, you can enroll like a 2-centimeter thalamic AVM and say, oh, I can treat this with radiosurgery. And then they randomized to watching versus radiosurgery. But a lot of those radiosurgery patients got edema in the thalamus, and then they developed neurological deficit. And many of them didn't bleed over 3 years. So, and so I think what was happening is that, and I think this is a problem with a lot of the surgical trials, because the things that are like slam dunks, people just don't want to enroll them. It's like they have a very hard time. And, nowadays it's very hard to enroll patients generally in many studies because, 20-year-old comes in with an AVM and you tell them, okay, well, I could take this out with like a 2 to 3% risk. Their parents want it out. I mean, because nobody wants to live with the unpredictability or join a trial and say, okay, we don't think these bleed. So you may not need it. So would you want to be randomized to one or the other? And they're like, well, I'd rather just not enroll and have the surgery. And this is what happened with CREST, right?
Yeah.
CREST 2, it's like very, very hard to enroll unless you have like a concerted effort to send every asymptomatic to a neurologist who's the PI. But if they go to the vascular surgeon first or the neurosurgeon, patients have already like gone in with the mindset that I want my carotid artery open.
Yeah.
It's very hard to like shift them to like, okay, well, you may not need it, And so I think the issue is really, it's just to really get an adequate is that there has to be like this force that just says, okay, you're just going to enroll every AVM, which I think is impossible to do.
Could you comment on the timing of the treatment for both ruptured and non-ruptured?
Yeah.
For the audience who's not surgeons.
Yeah. So I think that so for a ruptured AVM, for me, most of them I feel they can wait. They should be treated, but it's not like an aneurysm that has a very high risk of rebleeding in the immediate future. It's more a high risk over the first year. And so it's very hard to go operate on an AVM when the brain's swollen if there's a big clot. And so I typically there's this fine time period where you wait for the clot to like liquefy, but you could still use the prior hemorrhage as a plane to have already done some of your work. So you don't want to wait so long that it's back attached to the brain and you got to dissect it. But if somebody has a big enough clot that we need to go in there to decompress because of mass effect, then we typically will do the AVM acutely.
Great, thank you.
The question.
There's a question in the audience in the online. Can you give us your management strategies in young females with AVM and pregnancy? And Radha asked.
Yeah. So a young female who's pregnant with an unruptured AVM, you're not going to treat the AVM during pregnancy, but I think the question is probably more related to how do you manage delivery and the later stages of pregnancy. So I think the first thing that needs to be made clear is that with aneurysms, cavernous malformations, or AVMs, there's never been any proven benefit to doing C-section over normal vaginal delivery. So I always say that patients are cleared to have normal vaginal delivery. The risk of pregnancy comes from the fluid shifts in the third trimester. that happen because of preeclampsia, volume overloading, and so forth. And so that's what needs to be managed. It's not the actual act of normal vaginal delivery and the pushing that carries the risk. It's really just the third trimester and then the immediate postpartum period of managing like their hemodynamics. I'm assuming that's what the question.
Yes. Dr. Guzman has a question.
A comment and a question. First of all, thanks a lot for, I think, this very sensible talk. It's an important topic. And I think because of the bias that has been created through Aruba, a lot of patients have been withheld proper counseling by an interdisciplinary team. And as you mentioned, I think the AVM is really the paradigm for interdisciplinary work between all the clinical neuroscientists. So congrats on this excellent talk. My question is on the timing also. You said the waiting, and I have the same philosophy. Now, if we do see a feeding aneurysm, we would maybe just go do the aneurysm, then let the patient cool down and do surgery later.
I should have, I wasn't as complete. So everybody who comes in with a ruptured AVM will get an angiogram to look for high-risk components that may carry a very high risk of rebleeding. And targeted embolization is very good for those lesions. So you can wait because, remarkably, you would think that you'd see it on all AVMs, but you only see it like on 20% of AVMs. Most of the time, it's just nidus bleeding that the nidus that ruptured.
So we have so many neurosurgery experts over here. As a rare and stroke neurology head, what is your take on someone who has AVM or aneurysm but needs anticoagulation for stroke prevention, say AFib? And also comment on obviously non-ruptured, for thrombolytics for acute ischemic stroke treatment.
Yeah, I mean, my take is that whether you have an unruptured aneurysm or vascular malformation, include cavernous malformation, because we get a lot of these questions. Anticoagulation is not going to cause your lesion to bleed, but if it chooses to bleed because of natural history, then your bleed may be worse, is what I typically say. And so say you have a 4 millimeter aneurysm, the natural history is fairly benign in rupture. Not taking anticoagulation if you have AFib is not benign. And so the risk benefit favors taking anticoagulation. And if it's a 12 millimeter aneurysm, you're probably going to treat it, so it won't matter, right? But with AVMs, I think you just have to say, I don't think anticoagulation changes the natural history of the AVM. It just makes, if you hit the negative of the natural history, the consequence will be worse. But I don't know. Do you guys believe the same? Yeah.
So the aneurysm, intracranial aneurysm in the past has been a kind of absolute contraindication for TPA, TNK. And then there are studies who have shown that small series that none of them ruptured actually less than 7 millimeters. So, but the guidelines still didn't change. So I wonder, practically, if you know someone with aneurysm in the window for thrombectomy and also for TPA, TNK, what is your approach?
I mean, I would theoretically say that it would fall in the same category, though I will say my biggest pet peeve is that even at MGH, most of the neurologists want to follow the absolute strict guidelines. But then when it comes to like doing thrombectomy, they want you to like, so did you give TPA? No, we can't because the INR is like 1.5, but now you want me to do a procedure on this. And all those patients were excluded from the trial too. So it's like, okay, well, we're going to break all the rules, just do it surgically, but you don't want to break the rules on the from the medical management. And over the last like 5 or 6 years, I've seen people who got TNK and you went in there to do a thrombectomy and the CTA. Everyone's so focused on the LVO, they missed that there was an aneurysm on the other side. It's happened because everyone gets so focused on the stroke. And then the number of times like you're like, oh, thank God, like you've done the thrombectomy on an MCA, clot comes out, you shoot the picture and there's like a 4 millimeter aneurysm on the other side of your aspiration, you know? So, I mean, I think, look, as in many of these things, there's always some risk, and you have an LVO, you have a risk of having a pretty bad outcome. But, you know, it's just a matter of time. You're going to hit an aneurysm on the other side of the LVO that wasn't seen when you do the initial CTA.
Thank you.
Gary Friedman again, just another question, of course. The slides that showed the radiation damage, I assume it's delayed radiation necrosis. I seem to remember the magic number was 3,000 rads. How much are these patients getting, or is this tissue very sensitive, or is it just really so well focused you're killing everything in the process?
Yeah, well, that one was a fairly large AVM. So it was bigger than a 3 centimeter AVM. So the dose was higher to achieve a cure. So
Okay.
I don't do the radiosurgery. We have a radiosurgical group, but I think that it is still dose dependent and it is delayed. So it will take 6 months to approach. It kind of hits a peak at about 18 months. It follows the curve of when the radiation is effective on the AVMs.
Thank you.